This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Today's webinar will focus on breast surgery. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of the screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's webinar is co-sponsored by the Katz Institute for Women's Health. Here to tell us a little about the Institute is Catherine Blateau. Catherine is project manager for the Katz Institute in the Northwell Health System Center for Equity Care, providing women's educational programming for our community of women. Catherine has also served as the Nassau County Safe Kids Coordinator for the past 15 years and as a Master Health Educator certified as an American Heart Association Basic Life Support Instructor, serving as Regional and Training Center faculty. Catherine?
Thank you, Stu. Hi, everybody. As Stu said, I'm Kathy Bloteau from the Katz Institute for Women's Health. I'd like to thank Mather Hospital for inviting me here today to tell you a little bit about the Katz Institute and also to support their focus today on women's health. At the Katz Institute, we know women's health needs are unique. Our goal is to promote women's health and wellness through comprehensive clinical services, health education, and partnerships with you, the women in our communities. Should you need clinical care services that the health system offers, we want to help you navigate the healthcare system and share our resources for the best possible outcomes. If you just give me 1 minute, I'm going to share a video with you that will tell you about the Katz Institute in a New York minute. Let me just, okay. And just finding that video, here it is. Okay, let me just bring this back to the start. Thank you. Okay, and on back to you, Stu. Thanks.
Thanks, Catherine. Now I'd like to introduce you to today's presenter, Dr. Melissa Fana. Dr. Fana is a fellowship-trained breast surgical oncologist at the Imbert Cancer Center of Northwell Health System and the chief of breast surgery at South Shore University Hospital, formerly known as Southside Hospital. Her clinical interests include genetic variations and mutations associated with breast and ovarian cancer, improving quality in providing multidisciplinary breast cancer care, as well as oncoplastic surgery techniques. Doctor?
Thank you, Stu, and thank you, Kathy, for that wonderful introduction. So I am the chief of breast surgery at South Shore, and recently I have an addition of becoming the director at Mather, and I'm really, really happy because Mather has a wonderful imaging center, Fortunato Imaging, and has excellent partnerships with its community to provide optimal breast cancer care. So I'm happy to join Mather. We're going to touch upon advancements and innovations in the last decade or so in the treatment of breast cancer, understanding that breast cancer, the way it's approached and what it is much better understood and treated than 20, 30 years ago. Northwell Health System has really brought breast cancer treatment to the frontier in terms of advancing and offering the latest treatment and advancements that the country has to offer. In doing so, a cancer institute was recently created with our leader, Dr. Richard Barakat, who came over after spending a couple of decades at Memorial Sloan Kettering, and we are really excited that he's with us. So I want to begin by talking a little bit about what breast cancer is. I think that for those who have been affected, 1 out of 8 women in the United States will be affected with breast cancer, and breast cancer can also affect men. They know that it's not one disease because of the amount of information and the treatment and tailoring treatment that they've received. But for those who don't know and haven't been affected with breast cancer, it's really understanding that breast cancer is many different diseases. This tree and this image is really interesting because in the study of medicine and anatomy, one thing that I learned is that it's very intricately related to the world, nature, the body, etc. Understanding the way breast cancer works is really understanding nature and the way that works. So inside the breast, there are 2 main structures. One could be viewed as the trunk of a tree, while the other is branches and leaves or lobules. So we have 2 particular areas that breast cancer likes to originate from, either the duct or the trunk of the tree, or the lobule, the flower part, which is the lobule. 85% of all breast cancers come from the duct. And just realizing how far we've come. In 1895, the X-ray was invented. In 1992, Congress enacted Mammography Quality Standards Act. And at Northwell, we're utilizing intraoperative X-ray machines to review specimens, verify calcifications, but we definitely have come a long way and have advanced technology. Advanced technology that shows us breast cancers earlier. And these are unprecedented times with COVID affecting so many people and healthcare as an institution in general. One thing I want to just remind everybody about is that cancer, breast cancer, it doesn't stop, and we don't stop either. So at Mather, we have Fortunato Breast Imaging, amazing radiologists that are there to provide mammography and other imaging that's required to detect something or investigate something that's abnormal. Here we see 4 images. The first one we see is more gray appearing, and that is a breast on mammogram that isn't very dense. And so if there was an abnormality like calcifications or a mass, it could potentially easily be found. The second one has more density, so you see the white area, the third one even more, and the last one is extremely dense breast tissue, which is defined as more than 75% of the area of the breast covered in this white artifact that you see, but that's actual breast density. Sometimes I'll hear someone say, "Doctor, my breast is dense," but it's really not something on physical or clinical examination. Density is only related to how the breast appears on mammogram. And we have additional tools. We have 3D tomosynthesis, which is a 3D mammogram, breast MRI, which is looking at the breast, like utilizing magnifying glasses and binoculars. You could see close and far. And we also have contrast enhanced spectral mammography. So these are huge advancements in detecting breast cancer. Contrast enhanced spectral mammography is a substitute for conventional mammography in high risk patient population. And there are patients who cannot have an MRI. An MRI is a very, very sensitive study to detect breast cancer once a breast cancer is detected, to make sure there isn't another cancer in the breast or the opposite breast. Breast cancer does not spread from one breast to the other typically. It is focused in one breast, but bilateral or having breast cancer in both breasts is possible. So an MRI can help with that. But there are people who cannot undergo an MRI, and that's where we have contrast enhanced spectral mammography. So it's just important to note for us that we do have that latest advancement in breast imaging. Managing breast cancer is super important to understand for all of you and for all of us, because again, it's not a disease, it's many different diseases, and it's understanding the particular disease in order to tailor or personalize treatment. Here, we focus on biology versus stage. When I have someone who is just recently diagnosed with breast cancer and is sitting before me in my office, the first thing they want to know is, doctor, what stage am I? And it's interesting because I let them know stage matters less than biology. And that's sort of confusing initially, but what it is here we have a pea-sized cancer or a lemon-sized tumor. So both are tumors. The pea size is very small, the lemon size is larger. However, based on the biology of the cancer, that pea-sized breast cancer may require additional treatment from surgery, such as chemotherapy, not to shrink it down necessarily if it's so small, but maybe to prevent it from coming back. And it's important for us as a healthcare team to understand and personalize that treatment. While we can have a lemon-sized tumor, and based on its biology, and by biology I mean how fast are the cells dividing. The definition of cancer, and particularly of breast cancer, is two things. One, the cells live forever unless something is done. And just like we have a limited time lifespan, so do cells. So if there's a cell that internally changed and now can live forever, that's a problem. The second thing is that it can divide and have babies, duplicate over and over. And again, from a natural nature biological standpoint, there comes an age where we can't have children anymore. But these cells continue to duplicate. The speed in which they duplicate is really the key for how to treat them. The faster they're dividing, the more effective something like chemotherapy will be. So if I have a pea-sized breast cancer that is very aggressive and dividing quickly, it doesn't mean that it's going to double in size in a week, but it does mean that perhaps in that treatment, either before surgery or after surgery, that individual will require chemotherapy to prevent that cancer from coming back. Now, in terms of this picture in the center, this is a picture that I sort of have drawn and used to educate my patients, because knowledge is power. Fear comes from the unknown. Understanding an individual's breast cancer and the risk of it returning really empowers us not just to provide treatment, but to partner together to look for signs and symptoms of recurrence or just be aware. So in this picture, we have a breast cancer which has a body and it has 2 ears. It has the potential to have 2 ears. And those 2 ears are really receptors to hormones that would make it grow. It's its food if it has it. And one is estrogen, the other is progesterone. I tell some of my patients it's like TVs from when we were younger and they had antennas. And if you didn't get a good picture, you would put foil around it, manipulate it, and then the reception would come in better. So a breast cancer has a similar strategy utilization of these receptors. Not all of them, most actually, are dependent on hormones, estrogen and progesterone. And even if a woman is postmenopausal and doesn't get the majority of those hormones from one source, doesn't get those hormones from the ovaries, it does get those hormones from another part of the body. And so we can grab the cancer by its ears, which is really another way of saying how we can treat it by giving a pill that decreases the chance of that cancer coming back by 50%. If given before surgery, it could even shrink the tumor. Interestingly enough, and the bigger the ear, the better or more receptive it will be to that pill that will block it from getting its food. During this unprecedented time, this pandemic, we have had opportunities to revisit giving patients this pill before surgery that perhaps wouldn't have needed it otherwise. They would have went straight to surgery. But since there was a period of time where we couldn't do surgery, in hormone positive cancer, we treated with hormonal therapy. And we saw, once again, not just in the literature and the data, that it works. The cancer didn't grow. Sometimes the cancer shrunk. Sometimes the cancer disappeared. I have a couple of cases in people I operated on that there was no residual cancer. They started out with small, very strongly hormone positive, so ER 100%, PR 100%, and so that pill worked. Now, the body also matters. There's 3 types, 1, 2, and 3, and what it really means is grade 1 is well differentiated, grade 2, moderately, grade 3, poorly. The closer the cell is to its normal appearance, the less aggressive, the slower it's growing. The more different it is, the more aggressive it is, the faster it's growing. So grade 1, like a little kindergartner, is not super aggressive. Grade 2, third grader, could have potential for damage. Grade 3, high school kid, that's how I explain it to my patients, could have the greatest potential for damage. But what it really means is that in deciding about chemotherapy, which kills rapidly dividing cells, if we have a breast cancer that doesn't have ears, that's the most aggressive kind, no ears, no feet, and is grade 3, poorly differentiated, that's triple negative breast cancer, chemotherapy will be very effective at eliminating any cells, preventing that cancer from coming back, or even eliminating that cancer before surgery. Now, the feet is an interesting receptor. So there are 3 potential receptors here for breast cancer: estrogen, progesterone, and HER2/neu. And feet, like in a rabbit, would make it run away from us, and that makes it very aggressive. I don't want a cancer to have feet, but if it does, we are at a huge advantage point right now because we have tailored, targeted HER2/neu positive treatment. What does that mean? It means that in research, we have developed drugs that go right to the feet in the cancer and implodes it, gets rid of it. If it's given before surgery, when a tumor is 2 centimeters or greater, or is spread to the lymph node, in 67% of the time, there's not even cancer at the time of surgery. It's a complete response. We don't know if that translates to an overall survival, but it's very exciting when we can treat a cancer before surgery and see before our eyes that it completely goes away in terms of how that person is going to do. If there is cancer left after treating with either chemotherapy for triple negative cancer or targeted therapy with chemotherapy for HER2/neu positive cancer, we have another opportunity to examine that leftover cancer and see if the biology is the same. Or just knowing that it didn't completely go away, perhaps add further treatment. So that's where biology versus stage is very important. Also, in hormone positive breast cancer, so the most typical breast cancer has no feet and it has 2 ears. They could be 2 big ears, that would be most favorable. There's a test that we have and we utilize over the last decade. It's called Oncotype DX. It's a 21 gene assay. It's like the report card on the tumor. It tells us what is the chance of this cancer coming back after surgery in 5 years, in 10 years, in the breast or in the body. It's interesting because this allows us to be able to determine in hormone positive breast cancer who is going to benefit from chemotherapy and who is not. Years ago, any tumor greater than 1 centimeter that had ears and no feet, we would give chemotherapy to. And we knew that in about 30 to 40% of the time, those individuals didn't need chemotherapy for the treatment of that cancer. And chemotherapy isn't without potential complications and side effects, so we really want to get it right, and we can. And using partners like New York Cancer and Blood, who happen to be one of our sponsors for this lecture, our own medical oncologists within the system, we can tailor the treatment and identify those individuals who will need chemotherapy after surgery, whether they save the breast or remove the breast. Saving the breast, removing the breast, overall survival, the amount of years a person is going to live is the same. The difference is in the chance of the cancer coming back. When a woman has more breast tissue, there's a higher chance the cancer can return. So it's very important to understand and provide the additional treatment. Usually when a woman saves her breast, 4 to 6 weeks after surgery, when she's healed, she will need radiation. And that usually lasts anywhere from 5 to 6.5 weeks, Monday through Friday, 10 minutes of treatment, about 45-minute appointment. I always say that it's sort of thinking like taking the sun's energy and directing it toward the breast. It's not a medication given through the IV, it's high energy. And after that, if the cancer has ears, the person will need a pill for 5 to 10 years. However, in the proportion of patients that have a high oncotype score for the ear type of cancer, they'll need chemotherapy. The ones that have a low score won't. If it's a triple negative breast cancer, no ears, no feet, chemotherapy for anything greater than 5 millimeters. If it's a feet cancer, whether or not it has ears, chemotherapy with the silver bullet that I call it, targeted therapy that goes right to the cancer cell. And it's very important to select those patients who would benefit from receiving that treatment before surgery, because again, 67% potentially can have a complete response if we give this before surgery. That could mean less surgery, less complications, less side effects, and better outcome. Breast conservation versus mastectomy, even if a woman chooses to remove her breast or both breasts, it doesn't mean that there's a 0 chance of the cancer coming back, but it is maximum risk reduction. We say approximately 3 to 5%, and that's also influenced by additional treatment, but it isn't 0. So it's still very important to monitor and watch my patients in my practice who have had mastectomy for the treatment of breast cancer to make sure everything's fine. The highest risk period of time is the first 5 years, but for the entire time that we're watching, we are cognizant of any symptoms, any pain, any changes in the skin or reconstructed breast. Advancements in treatment, radiation, a huge advancement in the way it's delivered. Radiation, one of the potential complications is damage to the underlying heart or lung. And by developing deep inspiration, taking a deep breath in during receiving radiation, it proved to be cardioprotective. So that was huge. And another aspect is potentially giving radiation immediately during surgery. And not everybody's a candidate for that, but what we can look at patients to see if they're candidates for is decreasing the time. So if radiation was a half a gallon of orange juice that we're going to take a shot glass every day for 6 weeks, and we can increase the glass to a bigger glass, we have a shorter period of time in which to drink it. So 3.5 weeks versus 6 weeks. Surgical advances. That's the most exciting part for me as a surgeon, is to be able to assure my patient that just because we have this problem to deal with, breast cancer, it isn't really a problem because we have a solution. Not only do we have a solution in terms of treatment, but the images that sometimes come along with a breast cancer diagnosis of altering their body, themselves, who they are, how are they going to be able to be strong for their children or their partners, etc. I can assure patients that, look, you're going to look great. By the time we're finished, this cancer is going to be gone. We are going to do everything that we can to prevent it from coming back. And you're also, I'm going to establish your body as whole as it was before. So we have better techniques for localization or hidden scar placement, the way to identify to get the cancer out in early breast cancer, which for the most part, we cannot feel it. We have shifted from wire needle guided localization, which we still use in a lot of cases, but now we have also technology, including Savvy Scalp, which is like a little Boy Scout or Girl Scout, it's a small clip. I call it a Boy Scout or Girl Scout because it shows us as surgeons where to go and where to remove the tumor. And I'll show you some images. Oncoplastics, so we really shifted from providing radical mastectomies with scars that were debilitating to nipple-sparing mastectomy, hidden scar lumpectomy, or mastectomies that we remove the nipple areolar complex in, but we spare most of the skin. And in reconstructing the nipple areolar complex, it appears to be normal. Even in nipple-sparing mastectomy, though, when we save that outward skin, there's no sensation for the most part. We do immediate reconstruction with direct implant. So implant reconstruction after mastectomy usually is staged with a deflated implant, and every week water is injected into that implant until the desired volume or size, and then there's a secondary surgery to remove it and an implant placed. But today, with better surgical techniques and better technology, we have the ability to provide direct implant, place the implant at the time of surgery, or deep reconstruction, which I'll explain what that is. So saving the breast, really, this is a stock photo that I'm utilizing to illustrate that if I place an incision around the nipple areolar complex, I can get to a tumor anywhere in the breast. If I place an incision in the axillary folds or the armpit area, or beneath the breast, I could also get to tumors without having a scar that's visible. Wire localization is the traditional way we find in the operating room to remove a tumor. A wire is placed the morning of surgery to the area where the cancer is. And we also have the ability to provide Savvy Scalp guidance. And here is Savvy Scalp. You see the image with like the game console. It looks like that's a console that's in the operating room or in the radiology facility where the Savvy clip is placed. And it really is amazing. It's like the iPhone 25. And it shows us as surgeons the distance that we have to go to remove the tumor with that probe, which makes a noise in the operating room. And that clip is placed a week before surgery, 2 weeks, 3 months. If I wanted to place that clip in a lymph node that had cancer, knowing that my patient is going to receive chemotherapy before surgery, in the old ways of doing things, when somebody had a lymph node with cancer, we had to remove a lot of lymph nodes in a full axillary dissection, which carries a risk of a chronic swollen arm called lymphedema, as high as 20, 25, even 30% risk. With a sentinel lymph node biopsy, just removing the lymph nodes that would first be affected with cancer, and obviously knowing of one that was, we can tag it with a clip. The person can undergo chemotherapy. 6 months later, they're in the operating room, and now I'm doing a selected sentinel lymph node biopsy, removing a lymph node that had cancer before, and a couple of others, if they're sentinel lymph nodes, sending them immediately to the pathologist. And if there's no cancer anymore, no more surgery. So that risk of lymphedema can go down from 25, 30% down to 7% with a sentinel lymph node biopsy. Less surgery, less potential complications, less risk factors. This is amazing technology. We even have these radiograph machines. I call it an easy bake oven in the operating room, where when a lumpectomy is done, or even in a biopsy, excisional biopsy, or even a mastectomy, let's say in a person that had a cancer, received chemotherapy, the cancer was really superficial, close to the skin. I know there's a clip there. I can take an x-ray immediately in the operating room. And for this case, this is a stock photo from Sienna Medical, or from the Faxitron company, I'm sorry, to demonstrate that there is a cancer in the center of the specimen, the Savvy Scalp, and the clip. A clip is placed, a titanium small clip is placed at the time of the biopsy, as many of you know, and this x-ray tells me immediately that I have what I was supposed to get, bullseye. Now, a lumpectomy, this is somebody who had a lumpectomy radiation and they have an incision around their areolar, but if you look initially, it's very difficult to see. If you examine closely, you may be able to tell just from certain changes of the skin, but this is where we are at today in terms of oncoplastic surgical advancements. And these are just a few of our partners here at Northwell Plastic Reconstructive Surgery, all technologically amazing, also wonderful, empathetic people. I work with plastic surgeons that are partnered with our health system or in our health system, knowing that they're technologically superior to other surgeons, but also that they are as empathetic and available as we need them to be. So, you know, when things are great, that's good. They're great surgeons, but if there's a problem, they are the ones that are going to be there at Saturday, 2 o'clock in the morning, or Sunday, or to answer any question that you may have. And that is what we do as a team. So, plastic reconstructive techniques, where have we come today. We can do skin-sparing mastectomy. That means removal of the nipple areolar complex and removing a breast, however, reconstructing it to appear very natural. Nipple-sparing mastectomy. Robotic mastectomy has been performed here at Northwell. Immediate reconstruction. Autologous reconstruction means using your own tissue to reconstruct your breast. And that has multiple advantages. And this is a picture of someone, an individual who, my patient, had both breasts removed and utilizing the belly tissue had reconstruction called DIP, deep inferior epigastric perforator flap reconstruction. The belly fat with the artery and vein is removed from the belly, reconnected in the chest wall. That surgery can take anywhere from 5 to 8 hours. A belly button is reconstructed. Those are reconstructed nipple areolar complex. So you could see how natural and the form of the breast is achieved in a very natural appearing way. We can also provide nipple-sparing deep reconstruction, saving all of the exterior of the skin, including the nipple, knowing that the nipple mostly won't function. I say all the time, but there's a small percentage of patients who report sensation. There are surgical procedures my plastic surgeons perform, which is reconnecting nerves to provide additional sensation. So I won't say that everybody doesn't have any sensation. The middle picture is after the patient had both breasts removed, their belly fat was removed, plugged into the artery and vein, and you see a small window under the nipple, which is the tissue from the belly tissue. That's how we know that the flap or that particular surgical procedure is good, the blood flow is running through well. And then the last picture is several weeks later, it could be a couple of months later, when that opening or window, I call it like a zipper, is closed. And essentially the incision is really almost invisible. Nipple-sparing mastectomy, we can perform this young patient, older patients, as long as the cancer is 2 centimeters away from the nipple areolar complex, which will be visualized on imaging. This surgery can be performed. If someone had a large tumor, received chemotherapy, and doesn't have cancer after the chemotherapy or targeted therapy, they could potentially have this surgery as well. In this particular case, the incision was placed under the breast, and so all of the breast tissue was removed, and this was reconstructed with an implant, and the incision is hidden. Here's another nipple-sparing mastectomy, a young patient. And you could see the before picture. Actually, this patient had an amazing response to chemotherapy. You can see, maybe you can notice in the chest wall on her right, a little darkening. That's a port for chemotherapy. Wonderful response to chemotherapy, and had surgery 4 to 6 weeks. I think it was about 6 weeks after chemotherapy, with an immediate implant reconstruction and a wonderful result, saving the nipple areolar complex. I cannot treat my patients with optimal care alone. It's not about the individual, it's about our team. And our team at Mather consists of many different people, including the breast surgical oncologist, medical oncologist, radiation oncologist, coalitions, radiologists. Fortunato is an amazing imaging facility. I knew it from when I was in medical school at Mount Sinai, when I was at residency in North Shore LIJ, I knew of Fortunato and how good they were. Genetic specialists, nurse navigator, nurse practitioners, social workers, psychologists, psychiatrists, survival advocacy group. We have CATS Women's Center here with us today. Physiatrists, lymphedema specialists, wellness, mindfulness, dietitians, OBGYN, clinical trials, research, and tissue banking. And where are we headed for the future of breast cancer? Well, over the past 30 years, a woman's odds of dying from breast cancer have decreased by 1/3. And that really goes to identifying the biology of the cancer, early treatment with early diagnostics, and personalized treatment. Where are we headed? Well, we have research trials right now re-looking at immune therapy for the treatment of breast cancer. Circulating tumor cells, can we detect circulating cancer cells before a breast cancer manifests, or after it is removed and we're watching someone? Can circulating tumor cells be the key to diagnosing a recurrence before it actually shows up on imaging. Stem cells for the treatment, there are our body's foundational cells, and they are utilized in other cancers. We're looking at them for breast cancer. The key is better targeted therapy. Chemotherapy is a drug, it's multiple drugs that have been very useful to us in the treatment of many cancers, but it's understanding that chemotherapy kills all rapidly dividing cells. The faster they're dividing, the more effective it is. But understanding also that it affects our cells too. And so tailoring treatment to targeted therapy like the FEET type of breast cancer, HER2 positive cancer, like the pill for hormonal ear type, the ear type of cancer is really the key, and continuing to develop those targeted treatments. And furthermore, having targeted treatments for distant metastatic breast cancer. Stage 4 breast cancer means it has spread to the bone or the liver or the lung or the brain. And the truth of the matter is that sometimes when somebody presents with breast cancer for many different reasons, the cancer has already spread. And what I like to remind my patients is that that is not a death sentence, and that we have amazing treatments, and that there is hope. And we need continued better treatments, which we are developing, to keep those cancers quiet for years, decades, which we can do. And it's remembering that. So references are listed here, and I'm open to any questions.
Thank you, Dr. Fana, for your extremely informative presentation. If anyone has any questions, please enter them in the Q&A feature on the bottom of your screen. Dr. Fana, we have one question so far. What is the best way to contact you regarding my situation?
So I'm located, right now I'm located at Imbert Cancer Center across the street from South Shore University Hospital, and I'm very pleased to announce that we just looked at beautiful space, office space for Mather. So our office at Imbert, the telephone number there is 631-414-6894. My personal cell phone number, which I give to all of my patients, I always say, no one has ever bothered me in the years that I've provided my direct line. I get text messages and phone calls from people who need me, and I'm happy to provide any direction and care. Is 646-963-1000. And we have a team who will help facilitate, get your imaging, schedule an appointment, and for you to see me.
Thank you. Do we have any other questions? Why don't we give it a few minutes? Oh, we have another question. Oh, no, just the same person saying thank you.
You're welcome.
Okay, if there are no other questions, or if you do come up with a question at a later time, you can always email us at matherhospital@northwell.edu, and we will pass your questions along to Dr. Fana for an answer. Once you exit the webinar, please, you will see a link to complete a brief survey, and if you could complete that, your feedback is extremely important to us in bringing you more webinars and different topics. Thank you for joining today's webinar. If you would like to view other HealthyU webinars that we've already presented, you could find them posted at www.matherhospital.org/HealthyU. Dr. Fana, thank you very much for your presentation today. We appreciate it.
Thank you for having me.